Everyone. Hello, everyone. Good evening, and welcome to another Thursday Night Live with Chef Brackman. I hope you have all had a good week. Did you have a good week? So I hope you have all had a good week. I hope you didn't have such a big scare like some of us who live in Doha that heard sounds of missiles. Hello. Welcome. So today's topic is medications in the off-label use. So for this conversation, I will be having this conversation in my capacity as a healthcare professional. As some of you know, I received my diploma in nutritional therapy from the International Institute of Health and Nutrition, Ireland, last summer. So how many people do we have here? Okay, we'll just give them a few more minutes before we get started. So before we go into what off-label medications are and why they're prescribed, we have to talk about what on-label medications are. So on-label medications are prescribed exactly as approved by the regulatory bodies, such as the FDA, the EMA, or Health Canada. So for a specific condition, a specific dose, a patient group like adults or children, and for a duration, like, commonly prescribed medications are analgesics, antibiotics, anticoagulants, and there's usually a protocol for this. So when we say off-label use medication, it's prescribed in a way that is not officially approved. It's for different condition entirely, a different dosage, age group, or formulation. So basically today's conversation is why, and then the risk and the safety things that you have to think about if you're going to use a medication in an off-label use. So why? The main reason why medications are prescribed in an off-label use is that there's limited approved treatments, example, rare diseases, fertility issues, and autoimmune conditions. And usually a lot of fertility issues, some of them also have an autoimmune component. So also, there's not enough scientific evidence beyond what it is approved for. For example, metformin is approved for use in diabetic patients, but there isn't enough RCTs to approve it for PCOS. So doctors will generally prescribe it, and sometimes insurance will not cover it if it's prescribed in an off-label use. And then individualized medicine. You don't fit into the mold of the way something is usually prescribed. So it will be individualized for your case. Pediatric care, some medications are not tested on children. So maybe an anti-seizure medication is approved for adults, but a doctor might use their clinical experience to adjust the dose for a child. That would be an off-label use. Emerging research and innovation is also a driving force for off-label use medications. I will talk about medicines I have used in the off-label, but before that, I will talk about a rare disease that seems to have a lot of off-label interventions, and that is the chronic fatigue syndrome. It is a disease that is still not properly understood, and doctors, there's a lot of gaslighting of patients that have chronic fatigue syndrome because it's characterized by debilitating fatigue, post-exertional malaise, brain fog, unrefreshing sleep. But they can't find what to treat on a test. And so far, science suggests that some of the causes are the Epstein-Barr virus, which is a common human herpes virus, dysfunction in energy metabolism, and abnormal immune activity. So basically, they don't know. They can't treat it. They don't understand. So they keep trying to target different things. But since COVID-19 happened, there has become a lot of interest in chronic fatigue syndrome because a lot of people after having COVID had what we now call long COVID. So after that acute infection of the COVID, and you're no more testing positive for COVID, but you're still sick, like you're still coughing 3 months after, you still have debilitating fatigue, and you're having shortness of breath and a bunch of things. So there was a large class of people who were still having long COVID. And because of the similarities of the symptoms of chronic fatigue syndrome and long COVID, a lot of research has come and a lot of off-label interest. So a lot of antihistamine, intravenous immunoglobulins, antivirus, and a lot of things are being pumped into there and being researched. So usually, sometimes a big medical emergency would put funding, and then people who have had the disease for a while will start to trickle down new interventions to help them. So I wanted to mention that because that's one of the diseases that's very poorly managed at the moment. So we will look at risk considerations for using off-label medications. Evidence may vary. Some doctors will refuse to touch it. Liability and responsibility. So there always has to be informed consent. You need to understand what that medicine is made for and why it's being given to you. Insurance coverage is a big issue because sometimes these medications are not cheap and insurance will not pay if it's off-label. And then there has to be safety, it has to be properly monitored, and there are a lot of ethical considerations. So I will go into I have 7 medications that I have used off-label. I want to go through all of them. I want to explain to you what I learned so that you understand why we're having this conversation. Because a lot of people in this community are dealing with one form of fertility issue or the other, or autoimmune problems, or issues like this, and it gets to a point that the doctor starts to think about off-label medications to prescribe to you. So I just want you to make an informed decision. So the first off-label medication that I ever used was metformin and letrozole. They were prescribed to me on the same day. As some of you know, I have polycystic ovarian syndrome. At the time, I was living in Canada, and when I was living in Canada, I did not realize that healthcare could be that slow. October 2013, I went to the doctor and I went to the general doctor to ask if I could see a gynecologist because we were trying to get pregnant and it wasn't working. And she said to me, "Oh, I'm going to give you a referral." The way she was so enthusiastic, I thought I'll be called the next week. October 2013. I was called first week of March 2014, 6 months later, to make an appointment for 24th of March. You know what happened in that period? Between October and March the next year, I went from Canada to Dubai twice to see a doctor. I went in November. The doctor assessed my case and gave me letrozole to induce ovulation so that we could try on our own, and gave me metformin to manage my blood sugar imbalances. So letrozole is usually used in treatment of breast cancer. But a lot of women with polycystic ovarian syndrome do not do well on Clomid, which is the normal ovulation induction medication used. So that is why I was given letrozole. It's used in the same way. You have it from a certain time in your cycle for like 5 days, and then you track your ovulation. So I was given that medicine to use for 3 months. And then I was given metformin to also use for that time period. And metformin is approved for diabetic care and pre-diabetic care. And because a lot of women with polycystic ovarian syndrome also have dysregulation in their blood sugar balance and insulin resistant, it works. So those are my first 2 off-label medications. So now off-label medication number 3, Actos. I will tell you now that this is shocking to a lot of doctors in Europe because it's no more use. It has a lot of side effects, and there are a lot of countries. So from country to country, and I know a lot of you are international and you're very mobile and you at some point, your healthcare system in your country will frustrate you and you will think about going somewhere else to try. I just need you to know and take it into account that some medications that are being given in one place are no more approved for use in some other places. They have moved on. Like now, metformin, it's it. But I was in Dubai when I started my first IVF round. First of all, a guy looked at me, told me to go and lose 5 kilos very rudely. And then he put me on metformin and Actos together, which is already diabolical because two of them are similar, both anti-diabetic medications, but he put me on two of them at once. And I was on it. I did 3 rounds of IVF there. I had 3 pregnancies. I lost all of them. And then at this point, I went to Germany to investigate the miscarriages. Hello. So at the time I got to Germany, I was still on this metformin and Actos because my doctor wanted to know all the medications I was on. And he said, Actos, why? So what that told me is that if I was receiving this treatment in the first place in Germany, I would never have received Actos. But he was like, okay, you're on it, so you can continue. But once you get pregnant, you need to get off both the metformin and Actos. In that period, I did a lot of investigations about what was causing the miscarriage. And then I traveled to Canada. So by the time I came back, he had plans for how to start, but we were waiting for a cycle. And then I traveled to the UK. And when I got to the UK, I realized I forgot the Actos. I didn't have it. And I was in the UK for a week. So I went into a pharmacy to just say, can you just sell me the Actos? Because it's prescribed for me, but I don't have it. He said, no pharmacist to sell it to you in the UK without a prescription. So they called a doctor. And the doctor charged me £60 to mail the prescription. And then they ordered it. So I got it. I used it. So I knew that it was a bit more difficult because UK was phasing it out, especially for PCOS. So that was off-label medication number 3. Then we come into number 4, intralipid. Now, after miscarriage number 3, I went to this doctor in Germany. He's not just a gynecologist. He's a professor in immunology. Immunology is his bread and butter. He researches miscarriages, seriously. So they've done a lot of miscarriage research, and they came up with this intravenous immunoglobulin for women who have high natural killer cells, which may be aborting the pregnancies. So he explained it to me. It's an off-label use because this medication is usually used in cancer patients who are going to take chemo. But the idea is the same, to suppress your immune system so it doesn't fight the baby. And he gave me a bunch of research. And at the time, for the use he wanted to use it for, to prevent a miscarriage, they had 56% success rate. This guy knew his onions. Like, he wasn't guessing. And I will tell you about those guessing later. He was not guessing at all. He knew it. He understood it. He asked me to climb on the scale. I did. He took my weight. He pressed calculator. He explained to me everything. So when we were getting started, he said I had to take like 10 milligrams before embryo transfer, like the day before the embryo transfer. Then a few days, I'll take 5 milligrams, and I'll start taking like 5 milligrams every 3 months up to the 24th week of pregnancy. At this point, it sounded simple enough. Why not? Until I found out that 5 milligram in a 50 ml bottle, very tiny bottle, was 500 euros. So this is a gamble. This is very expensive. You're hoping it works. You're hoping beyond hope that it works. But he's not taking you for a ride because he doesn't make the intravenous immunoglobulin. He doesn't sell it. He doesn't care where you buy it. Now, there are a lot of gray areas in healthcare, and there's a lot of conflict of interest where I've seen people go to a fertility clinic and they tell you that only them will do all your tests. Simple tests like estradiol, very simple tests, pregnancy tests. They're the only ones allowed to do it. and are charging you 10 times what every other lab in the city does. That's abuse. So this man says, I don't care where you buy it, but if you agree to the treatment, then this is what you're going to use. Ha! It was as if they poured, it's tiny bottle, I'm telling you, 500 euros. It shocked me, but okay, what was our choice? We agreed to do it. So the first 10 milligrams, they put me on heart rate monitor. They put a lot of monitors because they wanted to be sure that my body will not reject it, because it's human intravenous immunoglobulin infusion. So you can see that the safety precaution is high. It's not what everybody does, right? I kept all my files from that treatment. So I know that my weight was 85 kilos when he started. And I know that weight was important where he killed it. And I'm going somewhere with this. When you're sick, especially when you're chronically sick, and it's a type of sickness that you've been seeking help, and you've done, each time you do a test, keep a record. Each time you've used the medication, keep a record. So that if you go somewhere else and they want to start repeating, no, I've done this, it's negative. You just show report. Then if it's that it's outdated, they can decide to rerun the test, but there's no need to repeat expensive tests that they don't need to repeat if you have a record. Tell them what medicine you've been on. Tell them what dose it was on. It's very important, and you will see why soon. So I started this treatment, and at some point he said to me that, yeah, there's a Romanian version of that drug, that immunoglobulin, Privigin, called, that was a little cheaper. It was 50 euros cheaper, so it was now like 450. So I started buying it. But this fertility clinic, after 8 weeks, you need to go and find your own gynecologist. So I was in Germany, and because I'd been overstimulated during this IVF, he didn't want me to fly. So he said I should stay in Europe. So I found another doctor, another German doctor, because this is a fertility clinic. So once your pregnancy is viable, you need to find another doctor to look after you. And I was twin pregnant. So my friend helped me find another doctor. So I went there with my prescription, and I explained to him very clearly that this is why I'm on intravenous immunoglobulin and I need it next week. The man looked at me and told me that he will not do that infusion, that it's rockstar medicine. You know, there's like celebrities and co, because they have a lot of money, they tend to get very far with certain things because they can pay, they can influence a lot of things. So he just looked at me and told me that he will not do the infusion. It's rockstar medicine. At the time, I was living with my friends, but things were still getting a little bit weird in the house, because I'd been in their house for already almost 4 months with the whole treatment. So I was now like, this doctor will not do this infusion. Let me take the train to the Netherlands. No, Henry came to Germany. So I said, let's go to the Netherlands. And if they agree to do this infusion in the Netherlands, then I can just stay at home with my parents-in-law. Every 3 weeks, I'll do it until I'm cleared to fly. Then I'll go back to Dubai. So, but in the meantime, I was doing the infusions at the fertility clinic, because I told that doctor that since the other doctors in Germany are refusing to do it. So I think it was those who had an immunology background that were doing it. So other normal gynecologists were refusing to do it, even in the same Germany that it was prescribed. So why I'm telling you this is that you should be careful in case you travel somewhere else to do an off-label medical procedure. You should know whether your doctors will support it or whether you will stay where it's being done for the duration. You get what I mean? So I got to the Netherlands at 13 weeks pregnant. I asked to see a gynecologist. First of all, you have to go to a house art, which is like a GP, and then they make an appointment. Then you go to the main hospital to see the gynecologist. So they wasted my whole time, ran a lot of tests. They actually did the 13-week scan and checked the tube and all that. And then I now explained to him that why I actually came is I want you to administer this immunoglobulin. The man said it's quackery, that he will not administer it. And not only will he not administer it, that no doctor in the Netherlands will administer intravenous immunoglobulin for miscarriage, to prevent miscarriage. I was shocked. So what happens that I now had to go back to Germany, pack out of my friend's house and move into a hotel. which was getting, so I was now sitting in a hotel so that I can do an infusion every 3 weeks. Either that or I do the infusion, I go back to the Netherlands, and then I come back in 3 weeks, spend the night in a hotel, do the infusion, and go back to the Netherlands. This is what I was doing for weeks, because also I needed to be in Germany or in Europe to the 20th week of the pregnancy, because I'd been overstimulated before this pregnancy started. So he said I shouldn't fly. So this was how my intravenous immunoglobulin went, but it was a success. Now, time to go back to Dubai, which was where I lived. Now I worried, what if they don't agree to do this infusion? What if they don't have it? So I went and begged my fertility doctor. I said, write a prescription for the rest of the bottles I need. Let's convince the pharmacy to sell them all to me. Then I'll put it in an ice box, take it back to Dubai, put it in my fridge. Then I'll go and look for a doctor who is willing to administer it. If I don't find a doctor who is willing to administer it in Dubai, I will pack them and go to Nigeria and sit for a few months with my father. He will administer them. He's a doctor. So that was just my attitude to it. So you need to think about these things, because there are some countries, they will seize it at the airport first. You don't have a clear, so hold your prescription, hold the explanation for the medicine you're carrying in. I got into Dubai without incidents. I found myself a gynecologist. I explained the situation very clearly. And he was like, oh, no problem. Just, every 3 weeks, bring the bottle. We'll infuse it. It used to cost me about $200 to do the infusion, but it was not a problem. We did this up to the 24th week of pregnancy. It was a success. Another off-label use medication that I was using in that same period was heparin, because they said I had a risk factor for thrombosis. So in addition to this intravenous immunoglobulin that I had to take to the 24th week, every 3 weeks, I had to give myself a shot of heparin in my thigh every night until a week before my scheduled cesarean session. That's why I have a picture on my page with a lot of needles. Remember that? Okay, so we have talked about, and the heparin was to prevent risk of thrombosis and blood clots, and also help support the pregnancy. So that was my 5th off-label use medication. And okay, so, I've missed one, intralipid. The doctor in Dubai, before I went to Germany, had read the research about intralipid, but he didn't know how to use it. So there's a lot of guesswork. If those who don't have an immunology background, they just guess. Sometimes they pull a report how it's used for its main cause. But intralipid is not like intravenous immunoglobulin. I will say I consider it quite safe because it's a food supplement. Intralipid has mainly egg and soybean. But if you don't have any allergy to these two, you'll probably be safe, because it's patients who cannot feed themselves. It's a food supplement that is administered in the hospital. It's a white, thick, milky infusion. So but the cycle that he tried to give it to me failed anyway. So I did one infusion of that the first time, intralipid, but it's used also to distract the immune system so that it does not attack the pregnancy. But intralipid is much cheaper than intravenous immunoglobulin. While intravenous immunoglobulin is a lot more effective, I checked the price. As of today, is about 572 euros for that small bottle. And intralipid is about maybe 90% cheaper. So you have to also look at these two options, more effective, maybe weak, whatever. But I met both of them again later, and I will come to that. So now, pregnancy number 5. I was now in Egypt. We tried to have another baby. So we got to this hospital in Egypt. So I explained to the man, I said, I have high natural killer cells. This is what I have been through before. So how are you going to proceed? The man said, oh, he has read a lot of research about intravenous immunoglobulin, blah, 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 blah. And then he said I should start with 20 milligrams, and that he will give me 15 milligrams every 2 weeks or something like that. I said, no. He said, what do I mean, no? I said, someone that my doctor in Germany is part of the research, and I know that your dose is too high, and that I was 85 kilos when I did it. And because I wasn't sure if you knew the dosage, I have made myself 85 kilos. If you were following me early 2020, you will remember when I lost 10 kilos. I didn't tell you guys why I was losing 10 kilos, but those who were following me then remember that drastic 10 kilo loss. I worked very hard the previous year into that January of 2020 to make sure that when we're touching intravenous immunoglobulin, I'll be 85 kilos. So I said to the man, I went and brought my file. I said, it's in German, no, but look at all the things I circled. You can see where my weight shows. You can see the dose. I said, you start with 10 milligrams, then 5 every 3 weeks, not every 2 weeks. Look at the cost now and all that. So he wanted to argue, but he had to go with it since it had worked before. So we started, and we started, and he also put me on, okay, that was after COVID started. I'll come to that. We started, I did the 10 milligrams before embryo transfer. I did the 5 milligrams after. Then COVID happened. They shut border. Medicines were not coming in. Egyptian military and people sharper than me raided the pharmacies. Like, even insulin was becoming scarce. So people just packed their essential medication because they were not sure when border will open. And all of a sudden, I did not have intravenous immunoglobulin. How was I going to continue this pregnancy? So I said to him that I have tolerated intralipid before, and I've seen that it has shown promise. That now that we cannot buy intravenous immunoglobulin, can we switch to intralipid? He said, that makes sense. So he agreed to it, and I went and bought intralipid up to the 24th week and lined up my fridge. Like, I didn't want to be careful. I bought it and lined, and somehow it worked. Maybe because we had already done the IVIG and started suppressing, but it worked. So I have used intravenous immunoglobulin alone and have not combined. But when this pregnancy started and COVID was happening, for some reason that I will never explain to you till tomorrow, and even all the doctors in Europe were angry, he put me on dexamethasone, which is a corticosteroid that eventually became a treatment for COVID-19. At the time, his reasoning was like, yeah, you're immunosuppressed because you're triplet pregnant, COVID is flying around, blah, blah, blah. But so that dexamethasone is used for severe allergies, inflammation, autoimmune diseases, and sometimes if you're going into preterm labor, they give it to you to help mature your baby's lungs. But you see that early pregnancy I was in, I had no business being on dexamethasone. And then let me tell you the cocktail this man put. So just so that when you're going for off-label use medication, do your research. Check the mechanisms of action of every medication so that you understand. Always know why a medicine was given to you. Because, for example, that heparin I was in the previous pregnancy, I was on that heparin again. So when I started bleeding, because I know that heparin is an anticoagulant which can worsen bleeding, the first thing I did was stop it. Even before I got to the hospital, I just stopped it, and they were trying to call my doctor. He was not in town. So I said, just put it on my file that until this bleeding stops, I will not take heparin. A lot of people are on medication. They don't know why they're on the medication. And if someone gives you a supplement, you won't know whether it will interact. Please understand your medication. Ask questions. Google is there. ChatGPT is there. If you don't understand, go back to your doctor and ask for further explanation. Please. It's very important. So with that, I'm going to group off-label use medications to those that are well studied, commonly accepted. The well studied and commonly accepted ones is that any country you go to, anywhere you go to, especially those of you that go somewhere else for treatment and go back, it will be accepted as acceptable therapy. So things like metformin, letrozole, most doctors worldwide will accept it for off-label for polycystic ovarian syndrome. Specialist dependent and mixed evidence. So things like intravenous immunoglobulin, heparin, intralipid, very specialist dependent, and not every country will accept it. So you need to be sure that the country you want to go back to continue the treatment will accept it. Otherwise, you might consider staying where you did the treatment till you finish that treatment. Because I had a big fight with the doctor in the Netherlands, because when he was calling it quackery, I said, I have been pregnant 3 times before this. You see that black line on your tummy when you're pregnant? I've never seen it before. Like, I was always, so this time, this pregnancy has reached 13 weeks that it has never, you're still doubting the science, you know? And then the third one is crisis-driven, then proven. At the point they started giving people dexamethasone for COVID-19, it wasn't fully established, but the promise was seen, and that whole use case during COVID has solidified it as a COVID-19 medication in some sort of way. So while I was pregnant with the triplets, I was having major fights with my gynecologist. Let me tell you what this man put for me so that you can know that off-label use can be 2 ways. You have to pay attention before they damage your liver, because some of them are using it for life research. That especially countries that the regulations are not so strict. They push a bunch of things, they're writing their paper. If it looks promising for a bunch of their life patients, maybe they'll put a research proposal and start the research, that kind of thing. So you need to be careful that you do not unconsciously, because of your desperation to have a result, become their lab rat. So when I was pregnant, it's quite common that when you become pregnant, especially with IVF, that you would get like progesterone support for 3 months, up to 10 to 12 weeks, to help before the placenta fully established and takes over making progesterone. This man put me on Dufaston, which is an oral progesterone. He put me on Cyclogest, a suppository progesterone, and then he gave me progesterone injection, not subcutaneous, not the one you can choke your tummy. Intramuscular. I had to do it on my butt. Henry was doing it. And then he said, because of maybe immune something, he gave me vitamin D injection. I had to do it every 3 weeks. Also on my butt. My butt was blue and black. Plus the heparin, which I had to do on my thigh daily. Then, so I had Dufaston tablets. I had metformin tablets. I had folic acid, high dose, 5 milligrams. I had calcium, vitamin D mix. I think it was Osteocare. I don't know why he gave me that when I had vitamin D tablets. I had Ascopid, a baby aspirin. And that one was the first one I threw out because I'm on heparin. Why do I still need a baby aspirin? Because it's quite customary to give you a baby aspirin on the day of embryo transfer up to 5 days after, to just help drive more blood flow to the uterus, to help improve chances of implantation. So I didn't understand why I needed to be on Ascopid for 12 weeks when I was going to be on heparin the whole pregnancy. So you understand what I'm saying? At some point, you have to start asking questions. You can't just be a live test subject. And then, of course, I've talked about the dexamethasone. And then he gave me, at some point, I became anemic because I was carrying triplets. So he also gave me an iron supplement, but it wasn't a pure iron supplement. It was a combination that wasn't doing much. So every morning I had like 10 tablets. It was horrible. At some point I said the medication to support this pregnancy might kill me faster than the pregnancy. So every week I fought for my rights. I got something scratched off the prescription sheet until things started to be said. And about the 20th week of about the 6th month of pregnancy, we had to evacuate because planes started leaving Egypt and we went back to the Netherlands where my kids were born. So by the time I got to the Netherlands and explained some of the medications I'd been on, the doctors were just mad. They were like, dexamethasone, they were really mad, which tells me that if I was in the Netherlands, I would not have had all that medication. Maybe all that medication supported the pregnancy. Maybe they were unnecessary. But at some point, I insisted to test my liver function just to be sure that I was still doing well. So, what am I saying? Off-label prescriptions can be expensive. They might not be covered by insurance. It's a judgment call, and it must be a collaboration between the doctor and the patient with informed consent. So please don't sleep on it. Anytime you're going to be given a medication that is not the standard protocol for what you're going through, ask a lot of questions, research it, get second opinion when possible before you get started. There's a lot of progress. There's hope for off-label medication. I am a witness. Intravenous immunoglobulins, intralipid, and a bunch of them. I'm a witness, so I'm a supporter for off-label use medication for specialists that have done the work, read the research, not people who are just skimming through things and just wanting to try things. So please be careful. Even the heparin, the doctor in Egypt gave me double. So I had to go and look for my Egypt file and my Germany file. I came, I said, no, it's half. And I halved it. So please pay attention. Any test you've done before, any medication you've been on before, remember the dosage. Remember how it made you feel. So that if someone wants to give it to you again, you can decide that, like, there was a time I had GERD, this gastroesophageal reflux disease that you'll be regurgitating stomach acid, and it was really painful. And I was put on a proton pump inhibitor, pantoprazole. Now, I don't know if I'm allergic to pantoprazole or if it's because I was on other medication. At the time it was prescribed to me for the GERD, I had metformin and letrozole. So I was using 3 of them. So I don't know if it's a combination of 3 of them or it's just the pantoprazole, but I was a leopard. I was covered in open sores, my whole body. But once I stopped the pantoprazole, the sores dried up and started going. So when I went to give birth, they ask, are you allergic to anything? At the time, it was my first surgery. I didn't even know that they give you proton pump inhibitors because they're going to give you painkillers to protect your stomach. I didn't know all of this, but I just said, do not even give me pantoprazole to save my life. They looked at each other and said, why? I said, because I will be covered like a leopard and I will be itching and I don't want to scratch up my suture. And they made a note quickly and they put a red band on my hand. This is why, whether you think it's important or not, if a medication, because you never know, if a medication has ever made you feel bad, once you're asked, mention it immediately. Because if I did not mention that medicine, that's what they would have given me. And you wake up from you come out from a CS, you will be groggy, you will swallow it before you realize what they've given you. So please mention it. So risks are taken when taking medicine in the off-label. So understand the risk, ask questions. Informed consent is very important, and it is a shared decision making. So you understand that you can walk away from it, you can decide not to do it. Do not endanger your life more. So find out what tests, what monitoring, what needs to be done to keep you safe while you're trying an off-label use medication. So I hope today's discussion has been enlightening and that you have learned something new or useful. I'm looking at my community. I love you guys very much. I love the support that I get from you. and I just want to give back. I want to keep us healthy. I want to keep us safe. I have private conversations with a lot of you guys daily. And some of the things that we discuss, sometimes I just feel, okay, I should bring it to the general house. It might be useful to someone else. It might be supportive to someone else. So that is why we're now doing this Thursday night lives. I hope you like it. I love your reactions to it. So we'll keep doing it. I have 35 topics. So I'm sure I have topics for the rest of the year for now, and we'll see how it goes. So I will be signing off now. I want to wish everybody a good weekend and thank you for joining. Take care. Bye-bye.